So, welcome to the third in our series of COVID-19 webinars. My name is David Levy, and I'm the CEO of EHE Health. Before we get going, I just want to acknowledge a technical issue for everyone, and that is sometimes my internet goes a little wobbly, at which point one of my colleagues who I can see will raise their hand. It usually only lasts for 5 seconds, so no need to worry, and then we'll get going again. I think we need to acknowledge today the tragic circumstances which we all find ourselves in, all of our communities, our country. We're obviously all inconvenienced by the social distancing, but as well, a large number are suffering significant economic consequences. And there's a growing number among us suffering directly from the health impact of COVID infection. Not just the infection itself, but the complications, hospitalizations, and I'm sure, like we at EHE Health, many of us know people who have in fact died. So we give special recognition and thanks and support to all of those, particularly those at the front line who have been working tirelessly, the healthcare workers and first responders and ancillary healthcare support to help get us through to the end of this terrible, terrible time. I think that we all have something to offer in all of our companies, for our employees, our families and communities. I think for the employers on this webcast, it's support, just like you've all been given in many, many ways to all of your employees and beneficiaries, which includes the need to communicate factually and consistently, and as well the leadership in taking social distancing seriously and thinking through how to plan for sure, when this comes to an end, how to bring all of our companies back to running order at the backside of this epidemic. This epidemic will end, not abruptly, but steadily, from mitigation to where we are now to containment and then elimination over the coming weeks and months. Today's discussion is about that future. Something I think we can all agree on, witnessing the recent past and the present, is that confusion is not a great thing. Rather, a thoughtful and evidence-based planning is paramount to realizing the best of our future, and that's where we want to think together with you. Today's discussion is first of a two-part series, the next being in 2 weeks, on how to think about safely bringing back employees to the worksite as we move as a society from mitigation to containment. We have two superb experts today to help us with these issues. The first, Dr. Andrew Rundle, who's a doctor of public health, a fellow at the New York Academy of Medicine, a scientific advisory board member for EHE Health for over a decade, and an associate professor of epidemiology at the Columbia University Mailman School of Public Health. Dr. Rundle's been a collaborator with EHE for over a decade and has published actively with us in refereed scientific journals on the impact of prevention on health in America. Just a few weeks ago, in fact, he published together with EHE Health and IBM Watson Health a major paper in the American Journal of Preventive Medicine on the use of preventive health services post-Affordable Care Act. Dr. Rundle will discuss his and his colleagues' use of sophisticated epidemic models to help local community hospitals plan effectively for capacity at various local stages of the epidemic. I'll then give you a glimpse of how we at EHE are adapting these models to be used for determining how and when employers can start to think about how to safely return to work and then engage in effective containment to keep your workplaces open. When I was a partner at PwC several years ago and led the team planning for the pandemic response for the state of California, one of the things I learned was how the law needs to be flexed in all sorts of ways in a public health catastrophe to address the crucial obligation of health protection of the entire population. This is a complex change of the legal constructs that we are used to and live by every single day, and these changes are wide-ranging. Delphine O'Rourke will lead us in this discussion. Delphine is an attorney and partner at Duane Morris. She's currently advising a broad range of companies, healthcare providers, and hospital associations across the country in preparing, responding, and recovering. Additionally, she's working with public health officials on crisis of care standards, immunity for healthcare providers and facilities, as well as state commandeering of property, including drafting legislation. Delphine has spoken on legal issues relating to COVID-19 with over 850 healthcare leaders, authored the first legal toolkit for healthcare preparedness, and has authored thought leadership pieces featured on educational sessions, including the CDC, and has been interviewed on multiple national media outlets. Her insights and commentaries have been featured by Modern Healthcare, Bloomberg Law, and Law 360, among other leading industry legal publications. Generally, we limit the panel comments to about a total of 30 minutes, leaving 30 minutes for Q&A. We'll be answering your questions at the end of the webinar. Feel free to email me those questions via Zoom by clicking the Q&A button below. I will then read the question aloud and direct them to Andrew or Delphine. And finally, after the webcast, as you all know, we have our COVID-19 support line, which is open to all of our clients and their beneficiaries, and that can be accessed toll-free at 844-258-1820. And so now we'll move ahead and we'll start with our first speaker, Dr. Andrew Rundle. Thank you.
Thank you, David. Good afternoon, everybody. Glad I could be here to present to you what Columbia is doing. As David said, we are now in the phase known as mitigation, and that's characterized by the closing of businesses and stay-at-home orders. We really need to get to the containment phase before we can really expect businesses to start reopening on any kind of large scale. And containment involves mass testing, contact tracing, and quarantining of infected individuals. So sort of moving back to a standard public health approach rather than sort of the emergency medical approach we are currently in. So Columbia University has been using epidemiological models to make forecasts of the number of new COVID-19 infections and confirmed cases for the coming 42 days, and we'll be updating these estimates every week. And we're looking at making estimates for every county in America. We're also modeling the healthcare system supply and patient demand to project if and when healthcare at the county level becomes overwhelmed. Again, we're doing this for a 42-day look forward period. And we're making these forecasts every week, and I'm going to show you some of the tools that we have built right now. So I'm going to share my screen. We have an online mapping tool, which you see part of here. I've zoomed into the Northeast. What I'm showing you here is our estimate of the number of critical care beds available in every county in America if every hospital system goes into a full surge response, basically does everything it can to provide healthcare, including double ventilating people. And the dark reds are places with low levels of healthcare or critical care beds, and the white are places that are well situated with a lot of critical care potential. I am currently in Hampshire County, so you can click on any county. This is probably too small to see on your screens, but it pops up the exact data for each county. In my county, if our healthcare system goes full out, we have 22 critical care beds available by our estimate. I am going to now stop sharing for 1 second, and then I'm going to reshare a different screen. The second tool we've built is a day-by-day forecasting tool for every county in America that allows you to look at our forecasts for new confirmed cases. The red line here is the scenario if only 20% of social distancing is accomplished, so a 20% reduction in social contacts. The orange line is a 30% and the green line is a 40%. So what you can see in these graphs is the critical role that social distancing plays in holding down confirmed cases and also holding down newly infected cases, which is here. The other thing that is graphed is estimated available critical care beds under the highest possible intensity surge that hospitals can mount. So if hospitals are going full out, these are the number of beds that are available every day in the critical care departments. You can look at the entire country, you can look at each state by itself, or you can look at each county. The moment I'm showing you California for Los Angeles County, and you see the red line, which is only a 20% reduction in social distancing, or 20% reduction in social contacting, I should say. And what you see is that red line is going down precipitously, whereas the green and the orange lines are holding steady where we have higher levels of social distancing. So the mapping tool is available online. The daily count graphs are going online, hopefully this week. And our point here is at the moment we're looking at these upward curves, but sooner or later we're going to start projecting out these downward curves. And so having information on which areas of the country have a low prevalence of cases, a low infection rate, and well-situated healthcare systems starts to give us the tools for really planning or coming up with a planning process that allows us to think about getting businesses back online and back to work. So these projections are going to be available. David obviously has access to them and to the epidemiologists at Columbia University. So I'm going to pass this back to David.
Thanks so much, Andrew. May I just ask you a quick question for clarification for the audience? Could you just give a brief overview on the data sources for your models?
Sure. So the models that that look at healthcare availability, we're using Medicare, Medicaid, federal government data, and we're also using the American Hospital Association data. So we've merged 3 large healthcare data sets together, and where the data sets didn't agree, we adjudicated, we consulted with critical care MDs to understand what kind of beds could be converted to critical care. So for instance, in a crunch, you can convert an operating room bed into a critical care bed and give up the ability to do an operation, but take care of an additional patient. And then Jeffrey Shaman at Columbia University is doing the modeling that predicts, based on county level data of confirmed cases, infections, and mobility patterns. He's doing the modeling for the counts each day of cases, and we wed these 2 data sets together to estimate when counties are going to run short or reach a crisis in terms of availability of critical care facilities. So Jeff Shaman, you may have heard of at Columbia. He's sort of been prominent in the news with some of the top models for estimating what's happening in the country and making forecasts.
Thanks so much, Andrew. Okay, the reason I wanted to clarify that, and so appreciative of Andrew reviewing what Columbia is doing, is that we believe at EHE that as we think about how to return employees back to work, that it's not really a question of, okay, everybody gets quarantined for 2 weeks and everybody all goes back together again. In fact, I was asked exactly that question 2 or 3 weeks ago by a client, and she said to me, that doesn't sound right. And I said, no, that's not really right. We need to look thoughtfully at the communities around the country to see at what stage of the epidemic, what the prevalence and incidence of new diseases, and when we're safely on the backside of these curves to start into feel more free to relax social distancing and to start putting into place some containment strategies. So I'm going to show you briefly a management tool that we've developed. We're going to bring one up on the screen now. Can only, there we go. So this is a dashboard that basically looks at hotspots and prevalence. And this is a sample employer where they have a whole host of facilities located around the country. And what a public health containment model does is it essentially does what I would call bread and butter public health 101 contact tracing. And if anybody has further questions about what a successful public health contact tracing methodology looks like, feel free to access the websites at the Minister of Health of Singapore or Taiwan or Hong Kong. These folks are pros. They got really a hard lesson around SARS, and they've been on this for a long time. And despite being so close to China, they have very few cases, and it's all around very disciplined contact tracing. And so we advocate that thoughtfully thinking about where we're down the backside of the epidemic curve and how we establish a system where who is cleared to work in the green, who is self-quarantined in the orange, and who is COVID-19 positive. That really drives baseline public health activity. And on the next slide, we believe that this can be helpful for large employers by separating out the function, work, and geographies. And even on the next slide, the management tool, it really looks at on an employee by employee base. As you can see, the state, city, site leader, work location, line manager, employee name, and status with respect to cleared, self-quarantined, and COVID positive. This is a modification of really world-class used public health standards, and how to take these and to put them into the context of an employer who has the obligation of managing a whole whole employee population around the country. So with that glimpse of how we use models and how we intend to use them to help employers get back to work safely, I'm now going to move to ask Delphine to make some comments with respect to these enormous issues about how the law has been flexed and how it changes and what that means to the employers on the webcast about how to start looking and solving problems and preparing a little bit differently than they might have otherwise thought. Thank you so much, Delphine.
Thank you, David. And I join you in recognizing the ongoing tragedy and echo your gratitude to the thousands of healthcare providers who are putting their lives on the line to save others. So as David mentioned, I've been advising a wide range of companies and healthcare providers since before the pandemic hit the US, when there was still a disbelief that we would be impacted. And some of my clients listened to the advice that I was providing on legal preparedness and jumped in right away. And others were still hesitant. We're waiting to see, when are the numbers going to hit? When are we going to see more cases? And I spoke to one of my clients this morning, who's a healthcare CEO in New Jersey, which you know is the second most impacted state. And he said, because we started right away and we started as soon as you and I talked about it, he says, I feel ready. I am fully ready. And I share this because if there are two things that I hope you can take away from my comments today, the first is that now is the time to prepare. That we do not know, as David mentioned, when we're going to be returning to work. There has been, as recently as last night with President Trump's statements, thoughts that maybe would full return, maybe it would be regional. We don't know at this point. What we do know is whether it's regional or a full U.S. return, there's going to be a surge of employees. And the more we can prepare, the decrease in the risk, and also it'll be safer for our employees and safer for our community. The second takeaway is that the law is different. We are in an emergency state when public health laws are informing the construct, and we'll go into some of those laws that will be impactful. And we need to balance those public health laws that provide relief and flexibility to help us manage the return to work process, and also be aware of those privacy laws, whether they're on federal laws or state laws that you're used to working within, and making sure that we balance both. So the three areas, thank you for the screen. The three areas that we're going to touch on today are, first, unprecedented times, and what does that mean for us? The second is the progressive cycle of employee transition and the legal issues to think about in connection with that cycle. And then the third is, how are we going to clear employees to come back to work? And what can we do legally? I mean, really getting down to the operational piece of how is it going to happen and what are the laws that are going to impact it? And recognizing that those laws are going to evolve between today and the time that we have a surge of going back to work. So let's start with unprecedented times. So as you can see on the screen, we are in a national emergency. And you all know that President Trump on March 13th declared a national emergency, which triggered a whole series of public health laws and relaxation of laws that were in play to be able to protect the public, really put the public ahead, protect our collective safety. So, and appreciate that right now we're still in the response mode. We still have thousands of patients every day who have COVID and are suffering through COVID. Now is the opportunity to return to work, to think about that, to think around the corner and say, how can we do that? We're here to mitigate, not eliminate legal exposure. Okay, and to do that through a holistic enterprise risk management strategy so that it's not siloed, so that it is connected to what's going on, both from a regulatory, from a clinical, from a public health perspective. So when I say, and I have clients who recently said to me, well, I don't want to have any lawsuits. And we said, no, that's not what we're looking at. A pandemic this large, this uncertain, that has affected so many people, the goal is not to have no lawsuits. The goal is to minimize those lawsuits, minimize that liability. Of course, ideally you wouldn't have any, but there's so much risk around this. So again, focusing on how do we make sure that that risk is as low as possible and that we do so in an organized way? And David touched on that. When there's confusion, poor decisions are made. And what we need to focus on is developing a process that minimizes the confusion. And just say this, there are advantages to these change in regulations. We can benefit from the public health framework, and important to utilize to maximize the flexibility that we currently have during this emergency pandemic to return our employees back to work. So for example, if we didn't have an emergency situation, there are certain questions we couldn't ask of our employees. There's certain information we couldn't share. But we need it. We need it to be able to respond to the COVID-19. And that's what we mean by the second point. The law is different in a public health crisis that we're in now than it is when we're during normal operating procedures. So the second area that I want to touch on is this progressive cycle of transition of employees. This is not going to be a switch on, switch off, everybody returns to work, everyone's cleared, now and forever. So there is a possibility that, as I said, it's phased, that it's by region, that using, tools like the tools that you saw where we can really drill down on specific areas, that it's going to be a staggered approach. And that employees might be fine and test negative, and then 3 months later travel and come back positive. So to be able to manage that cycle. So information, important to know what information can you ask employees when you come back to work? What can you ask them about their travel, about their fever, and not run afoul? What information can you share about an employee who's been positive? Who can you share that information with? Again, you need to make sure that you protect the safety of your employees, the safety of the community, and balance an individual's privacy. So if someone, for example, tests positive, you can't send out, for example, their name and location to the entire company. It needs to be tailored. And then HIPAA, a lot of confusion around HIPAA and what employers need to do to follow the HIPAA guidelines. HIPAA applies to healthcare providers, healthcare plans, healthcare clearinghouses, generally covered entities. So you may well not be covered by HIPAA. So don't be, if you don't have to be, restricted by that regulation. And there's already some flexibility around HIPAA. So really important to understand that. Now, moving on to testing, whether it is at the core of a return to work is how do we clear employees? What is going to be the process? What are going to be the criteria, the guidelines, so that we can say yay or nay or maybe, and ensure that when we give that thumbs up, that the employee is safe, their colleagues are safe, and our community are safe. So on testing, suggested guidance as recently as end of March, that an employer can test all employees if COVID-19 is posing a direct threat. Now, we anticipate that as the number of patients increases and the number of deaths increases, that there will be more relaxation around this. So at the end of the day, it's going to be what's enough? What's enough of a guarantee that my colleague doesn't come back to work and infect me? So an area to watch. Performing temperature tests. We've been having conversations around that for weeks now, or self-check. So asking your employees to self-check. Again, you can do that under this environment, but it needs to be carefully tailored to the COVID response with the goal of, meeting the public health needs. And then, consent. We want to make sure that on the back end, first of all, employees understand what we're asking them to do. And on the back end, that we don't have liability where employees say, you know what, I didn't understand what you were doing, or I didn't give you permission, and my employer, to share that information. So again, under the public health laws, there's flexibility to obtain consent, and important to tailor those processes so that you're balancing the privacy and the public health needs. So with that, I'll turn it back over to David.
Super, Delphine. Thank you very much. Before we jump into the Q&A, I just want to add just an observation that we had at EHE. We were very careful early on. Back in January, people called me Dr. Doom and Gloom, but and early on we started in February to do daily temperature checks and screens of travel and the like. And I went up to our clinics and talked to our employees up there and to the patients. And even though employers might think that this is an onerous thing to potentially ask employees to do, to take their temperatures and to go through a daily screen, or even ultimately when we get testing available to be tested, I can't tell you how grateful everybody was about feeling like they were in a safe environment. So this isn't normal times when we're asking people to do something onerous for the quote benefit of management. This is really a time where we're actively contributing and people feel very closely the positive effects of taking the utmost care and doing everything that one can to keep an employee population safe at work. So they're really, even though it may be somewhat thinking about the problem differently, it turned out for us, we thought it was going to be difficult to implement, but our employees were generally grateful for having done those things. So now I'm going to jump into the Q&A. We've got about a half an hour left. We can always stay. The last one lasted a few minutes after, so we're a little bit flexible. To do the Q&A, you have to click the Q&A button on the bottom and then type in an email, and then I will direct the question. Okay, so the first question here is, when do we think this is all going to end, and when are we going to come back to work? So yeah, that's the question everybody asks, and obviously it's the most important question. And the unsatisfactory answer is it really depends. And as I think Andrew showed pretty clearly, and I'll ask him to comment on this, there are a number of factors at play here. The first, as you saw from his models, is how good we are at social distancing, moving away from a tidal wave of cases and just pure defensive mitigation to coming down to social distancing, to bringing the numbers into an arena where then we can hopefully get our arms around it, which is obviously key when you think about how many tests are available. So one is social distancing and how effective we are, how compliant and effective it is. The second is how many tests can we make available? Ultimately, I can't imagine why everybody wouldn't want to have everybody tested before coming back to the workplace. We simply don't have those numbers of tests available. And then the third issue is when you start doing tests and you're into the containment, is what kind of a management system do we have that we can put into place to make sure that we are breaking lines of transmission. This virus transmits in clusters. I cannot say this loudly enough. People tend to anthropomorphize this virus. There's no behavior, there's no human behavior in this virus. This is purely about math. And the way we can deal with the issues of math is going to call when this will happen. So we are feeling like if we do our best at putting into place great public health, contact tracing, flooding the market in the next 2 to 4 weeks with testing, as well as being really effective at social mitigation, hopefully in the next 6, 8, 10 weeks, we can start seeing a thoughtful return to work. But I'm going to turn to Andrew to comment on that as well, because you're the modeler and you see what's going on around the country.
Yeah, this is what I would add to that is that we need mass testing to come online. I'm sharing my screen again, and I'm showing a map here now with the counties highlighted that are going to basically be overwhelmed in the next 42 days with cases, even if the hospitals are all working flat out. So one of the signals that we can go back to containment is that our healthcare system is no longer on an emergency footing, but it is back on a regular footing. And so over the next 42 days, we've estimated across the country all of the counties where their healthcare system is going to be overwhelmed. Those counties are going to need time to recover their healthcare system. These doctors are working flat out. You can't do that for like 30 days, 40 days, 80 days. So part of it is going to be, when does our healthcare system get back onto a normal footing? And we'll need to see that really before we can really have mass openings of businesses. So I can share actually this URL for the mapping tool is publicly available through EHE for you guys. So you can play with the data yourself. There's a lot of data in there, but mass testing and a healthcare system that is off of an emergency footing and back onto an everyday footing, I think, are the two key signals that we are getting ready to come back in a serious way.
Great point, Andrew. Thank you. So the next question is, regarding temperature checks, is there clinical data showing that this is effective? So I haven't seen published studies on that, but what I will tell you is for those of you who travel like I used to a lot in certain parts of Asia, temperature screening is part and parcel of the core public health activities in Singapore, Hong Kong, for sure in Taiwan. And it's a key part of the strategy, particularly when testing is not available to everybody. But Andrew and Delphine, do you have any other data sources to answer the question specifically?
I don't. We do know that people who are asymptomatic can transmit the disease, which makes people concerned about the temperature checking as the sole tool. The other way to think about it is if somebody does have a high temperature, then that is definitely a warning signal that we want to see and not ignore, right? So no, temperature checking won't capture every infectious person, but it is a tool in the toolkit that we can't ignore.
I have a next question, and there's a bunch of them are on temperature checks. With temperature monitoring, how would you manage an event if an employee starts developing a fever during the workday after they've had their temperature when they report to work for the day? So this is a great question. What happens if somebody comes back to the workplace, they're COVID-19 negative, they come in and they're fine and they develop a temperature? Everybody with a temperature ought to go home, period. And they ought to self-quarantine until we can establish that that patient is COVID-19 negative. If they are indeed positive, intensive contact tracing at the employer site, as well as in the household, and report to local community public health resources and in the community as well. Every single positive temperature until proven otherwise has to be viewed with caution. Literally, you could not get into any of those countries that I mentioned if you tried to cross the border at the airport with a temperature without extreme disciplined management. And then the next question is thoughts on thermal screening for non-healthcare workers. Just to be clear, we did this at our own company, and we believe that this is for all workers, not just healthcare workers. Temperature screening is an important and crucial tool, as Andrew said, in the toolkit for early detection. You know, it's not necessarily highly specific. It may be sensitive, but not highly specific, you know, and you might end up having lots of false positives with respect to actually having COVID. But in the end, it's the right cautionary approach until you can verify. Andrew, by the way, discussed Jeff Shaman just a few minutes ago. Jeff was a co-author at Columbia, at the Mailman School. Jeff was a co-author on a really informative article that was published in Science about 2.5 weeks ago. And there's an important nuance here that came out of that article, which is that 80% of people who got COVID got it from somebody who was not symptomatic or had such mild symptoms that they didn't even consider themselves ill. What that basically means is when you test individuals, you're not actually testing to see if they're sick, only if they have fever and the like, and that's mostly today done in hospitals and checking people go through the ICU. The act of doing a COVID-19 check or a temperature check is not just for the individual, but it's for the public health, because most COVID cases come from people who are asymptomatic. And that is what has made this disease so dangerous and so prevalent. Yeah, Delphine?
Yeah, happy to build on what you've said. As far as the return to work, we're already seeing that healthcare facilities, physicians are strained, and we're seeing reallocation of physicians already. And in New Jersey, for example, an executive order was issued giving the governor authority to move medical personnel from one facility to another. So as part of this back to work is also anticipating when everybody wants to go back to work and also wants to be cleared, the healthcare facilities are going to be now inundated, not with COVID-19 patients, but with another category of patients. And that's going to play into it. Also, on the question of if someone comes back and has a fever, that goes to the comment of cycles before. That's going to happen. And I would say same advice that we gave before. If someone has a fever, they leave work immediately and to continue those protocols. It's not going to be one day everyone's sick or quarantine and the next day everyone's fine. So we're going to continue to have that heightened awareness around symptoms. Also appreciating, as David pointed out, that 80% are asymptomatic.
Could you please can you answer this, the issue about establishing temperature checks at all entrances after public health emergency expires? What about the use of technology to screen temperatures ongoing, such as temperature sensing equipment cameras? So I think the first part of the question for Delphine is, after the public health emergency expires, can you continue to have a protocol of screening everybody's temperature when they come through the front door? And then to make it easier, as you know, seen in some of the airports, particularly in China, you know, there's these automatic temperature sensors as you come through immigration. And what about those technologies and how they impact employers? So maybe you could take a crack at that, Delphine.
Sure, happy to do so. So, you know, temperature checks are based on the risk that the employee poses in these situations of COVID-19. So once the public health emergency expires, what we'll want to look at is what is the risk that one of these employees brings or contaminates others with COVID-19. So in theory, yes, you could have checks, but if we're at a point where the threat is so limited, you need to balance that against individuals' privacy. That said, is, you know, if your screening is reliable, if it's effective, if it's performed consistently, respectfully, and non-invasive, you know, already now there's a difference between taking someone's temperature with a forehead scan versus taking somebody's temperature with a thermometer. So to balance those out and to make sure also that you have personnel who's screening that is qualified. So you might be already paying a security guard to be at the entrance, not the individual that you want to have screening. You know, before 9/11, we didn't have security stalls in every building in New York, and now we do. And I wouldn't be surprised if we start seeing those automatic temperature checks, because the human-initiated one by one, I know it takes time when we start getting to high volumes every day.
Okay, I think this was another one for Delphine. Based on these public health laws that give you additional freedoms to check for safety of all, if your workplace is a place where the public enters, for example, a mall, can the owner of the mall test people entering their space before allowing them in addition to their employees?
That's a great question, you know, because you want to keep your customers, if it's, you know, your customers and your employees safe. And because malls or other locations where people congregate, those can become clusters. So very important to think about those public spaces. So the short answer is, again, if it helps to reduce the rate of COVID-19 spreading, you can test. You can also provide medical questionnaires, you know, including some of the questions around what symptoms are you experiencing, where have you traveled. And you could also do that if you're not in a public, if you don't have a mall, for example, but you have visitors coming to your building, you can do the same thing. Again, guidelines need to be reliable, non-invasive, consistent, professionals who are providing these services. But we're going to need to really focus, and particularly in public space. And remember, you know, if you're inviting people to your space, you have a heightened duty to ensure their safety, overall safety.
You know, just on that note, we actually at EHE Health, we actually took everybody's temperature, including outside contractors and visitors, as well as obviously patients who came into our clinics. One of the, and people seem not to have any problem with that, but one of our clients really asked a very interesting question, which is, what about when your workforce is a traveling workforce and they go into other places? Can they make any demands about their safety, even though they may be a contractor, with respect to the sites where they're being asked to perform work as a contractor?
Yeah, again, another great question. You're getting into these details. So, I would make the argument that you can. These are partners, okay? So I'm not talking about, you know, U.S. Postal Service. That's a different dynamic. It's a governmental agency. You know, work through that. But if you're contracting with the contractor who comes in, maybe they're cleaning, maybe they are fixing your photocopying machines, whatever they are. Because those companies, I have clients that are on that side, and they're concerned that they're not only potentially contaminating because they're going from spot to spot, like a bumblebee, but also that the spaces that they come into aren't safe. So I would start with a conversation and ask your partner, what are you doing around this? And that you can have mutual expectations.
Great answer. Okay. Next question is, mass testing is for a point in time. So on a return to work basis, how often would you see testing taking place? So our point of view at EHE in this regard is on a one-time for the first return to work episode, everybody ought to get tested. And in fact, on my employee webcast Monday, when we talked about the future and how we're going to bring people back to work, I said, we're going to implement, hopefully when we hope tests will be available, point of care tests, that in fact, everybody will be tested before they come back to work. We don't believe that you have to test multiple times the same person unless they've had an incident such as a close contact or a fever or a flu-like illness. And then upon return to work after an episode, it would be appropriate to retest if, to be certain that they're not actively infectious. This one's going to be for Andrew. One of the issues in having employees return is the support networks to enable them that being up and running, such as childcare, schooling, etc. Even though the president may be giving a back to work issue or order, we have seen countries such as Hong Kong have a second spike. What evidence are we seeing that a second wave could occur?
So right now in the United States, we don't have evidence because we're still getting through the first spike. My expectation is, yes, we're going to see second waves in places who've hit their peak and then come back down, because across the United States, we're not all running the same speed in the same race. So there are multiple epidemics unfolding. So clearly New York is, on the vanguard in terms of the time to when it's going to peak. When, excuse me, when New York gets done with its massive peak, there's still going to be 7-8 million people in New York City who are susceptible. And that is just a great scenario for a second wave. The key here is, though, if we can get into a good containment space where second waves can be handled using standard public health approaches and not falling back into these emergency approaches, which we've all going through currently. And so, there's been some evidence in Hong Kong of them having to re-lock people down because of a second wave. Hopefully that will not happen here if we can have testing, contact tracing. So we need our county public health offices to be able to do the contact tracing at the county level. In David's point of view, the companies are going to be helping with contact tracing within the workplace. So we need to be focused on this public health response. There will be second waves, or third waves, but in certain places in the United States, I'm convinced. But having a game plan in place to monitor and contain and then quarantine people who need to be, I think we can stay ahead of it. But yeah, it's not going to surprise me if we see second waves at all.
Yeah, just to add to that, if you look back from at 100 years ago in the Great Flu Pandemic, there were 3 waves, but they didn't have the same tools that we have today. They didn't have the testing tools. They didn't understand the nature of containment. Everybody probably has heard and seen the story of the difference between the parades in St. Louis that were called off versus that in Philadelphia, where the former had almost no cases and the latter had a huge number of cases. I think that with great containment that we really mitigate or minimize a massive, the impact of a potential second wave. I mean, this only goes away when all the lines of transmission around the world are ultimately broken and the virus dies out. And one could argue that maybe in 3 to 6 months, a fabulous antiviral therapy that essentially cures everybody, the 10% of people who have significant symptoms and or who can go on to hospitalization and death, that with the rest of the people and with relaxation of social distancing and allowing the virus to circulate, you can build up herd immunity or immunity in the community without harming people by virtue of an antiviral therapy. It's potential that sooner rather than later we can raise the general level of immunity in the community. So, you know, there's a lot of ifs here, but basically the core focus is public health 101, containment and testing. And then hopefully as we move into antiviral therapy in the next 3 to 6 months, and then hopefully a vaccine in a year to a year and a half, we'll be able to relax completely, as it were. The next question is, when can we clinically allow a person to return to work? i.e. is using CDC guidance 7 days after onset of symptoms, 72 hours of fever-free safe, in view of some of the evidence one might be asymptomatic and contagious for a longer period of time. By the way, I'm not going to name the person, but I know the person who asked this question. He's a physician. And I mean, I wish I knew the answer to that question. And I think, I mean, it's appropriate at this point. At EHE, we use, you know, national guidelines like the CDC. The best answer to the question is we're going to have a lot of information in the next few weeks. And by the way, that question doesn't just extend itself to symptoms as it relates to safe to return to work. As we all probably know, there's antibody tests that are now available and being developed, serology that look at both IgM and IgG, supposedly conferring longer term immunity. And what does that really mean? If you're IgG positive, can you still be carrying the virus and not have the disease? Can you be shedding virus? I think, frankly, that this is something that we're going to learn a lot about in the next 2 to 4 weeks. But it's impossible to have a perfect crystal ball. I think I just want to go back to Delphine's comments, which is the idea here is to think about this systematically, to address the changes in the environment as new data becomes available. I think there's nothing dumber than staying to your own point of view, even though that the data has changed. I mean, we have to all be flexible and look at incoming data and make adjustments in a methodical way based on the incoming data about what happens. Delphine, maybe you want to comment on that? Yeah.
I get this question a lot. When are we going to return to normal? When are we going to get back to normal? When are we? And I would argue, and maybe I'm with the David, the sort of doomsday camp, but I think there are events that shift the paradigms, and they shift the paradigms of how we interact, of public safety and the law. And like 9/11 really shifted the paradigm on public safety. You know, now somebody looks in your purse, you don't think twice about it. Even if, you know, they're just they're a security person, look in your purse, no big deal. That we're gonna see a shift. And maybe looking at healthcare providers, they already have certain requirements. They need to have a flu shot, no acrylic nails, whatever it is, that we're gonna move in that direction where to employees, what previously was seen as encroaching on their privacy and self-expression for the benefit of the whole. So I don't think it's going to come back to normal. But what is required to, obviously we defer to medical experts and the CDC and others, but from an employment and employment law context, I think we're going to see a transition where there is going to be a greater lean into individuals' privacies for those, for the greater good. Getting back to the testing question, if testing is necessary every day, well, testing is necessary every day if that's for the greater good. There are alcohol tests, drug tests in other professions to ensure safety, and you want to make sure that your bus driver is tested as frequently as possible to achieve those ends. So that's my thought on those.
Super, thanks. Okay, this next question is a really, really big question. It's going to be for you, Delphine, and good luck with it. How do we consider the psychological effects here? Whilst we can practice social distancing back in the workplace and extended cleaning, the mental aspect is hugely prevalent. What are the legal risks of mental/psychological claims?
That is a big question, because there are many aspects to that. And we are finding already that the toll of being socially distanced, of such a disruption and stress. So there is a risk of claims already brought, and we're already seeing some, that employers did not protect their employees by acting soon enough. Of course, for healthcare providers when they don't have PPE, and we should expect to see claims for emotional suffering and distress. or post-traumatic disorder linked to an employer's failure to provide a safe environment. And that's why the component of bringing people back to a safe environment, if they are stressed about coming to the environment because they don't think you've done enough, then your risk increases. If you can't remember who was tested, who was not tested, where they're, that's where your risk increases. But, another aspect that I'm seeing clients do is proactively reaching out and thinking about how are we going to transition people back? What are the EAP services that we can provide? How can we screen them? Because it's safety from infection from COVID, but also safety from somebody who cannot bear the stress and therefore, has adverse reactions. So anything, and that's, so on the legal side, it's permissible to ask specific questions about their stress. Obviously needs to be carefully crafted, but if they are hesitant to come back to work, and that would be part of the return to work process, to protect everybody else. You don't want someone to become unhinged. But that goes in the category of, you will have some. Right? There will be people who are more affected than others. So don't be surprised. The question is, you don't want to have hundreds of those or a class action of some size.
So can I just ask a very specific question on that, Delphine?
Sure.
Based on this question, should employers be doing something special when people come back to work on the mental health side, with respect to putting them through a series of, mental health screens of some sort? I mean, is there an obligation? Not only could they be depressed and suicide, people can be harmful to others if,
Sure.
And should employers consider not just doing COVID testing and maybe simple physical exam things, but, a more significant mental health assessment?
I would recommend that employers do that because, again, you're responsible for providing a safe and healthy environment, and safety from others is part of it, right? People undergo a traumatic experience. Maybe we're hearing, here in New York City, people whose entire families are dying of COVID-19. We don't know what the situation and the tragedy that our employees went through while they were being quarantined. So to ask a question like, are you feeling any stress or anxiety relating to return to work? Are you, the questions that are carefully crafted, and again, it needs to be just what's necessary. Okay, it's not, your whole life history, and it needs to be done in a consistent manner. So if you're going to ask that question, ask everyone. If they say no, move on. If they say yes, these are resources. This is what we can do. You're protecting them, and you're also protecting yourself and your other employees from having somebody who maybe is violent and is not safe either to themselves or to others.
Okay, that makes a lot of sense. All righty, let me just check. There's no more questions, and that's perfectly timed. We have 5 minutes left to the top of the hour. Maybe Andrew give a 1-minute summary, and Delphine, and then I will, and then we can call it quits. Andrew?
Yeah, I think my takeaway is we, comparing, as you said, to the 1918 pandemic, we have a lot more tools, and part of that tools is projections, forecasting, and modeling of what's likely to happen in the future. And there's these kinds of tools that are going to be useful in a organized planning process for bringing companies back online. And so that gives me a lot of hope. We're going to be updating our projections weekly. We have like a multitude of PhDs working on these projections, taking into account the newest information we can get our hands on. And so having 6-week look forward projections on the state of the healthcare system and the number of new infections is gonna produce useful planning tools. And I think the message here is like, we didn't have a solid plan going into the pandemic. We do need a solid plan coming out of the pandemic to minimize risk, but also get our economy back up and working again.
So I'm going to build on Andrew's
thank you.
comment.
Can you hear me?
And you're right. And you teed it up perfectly for me. We didn't have a plan going in. Nobody thought it was going to happen. Mixed messages, and my concern is we're going to have the same situation. There is understandably a huge push to get the economy back up and running, for companies to end this business interruption, which is having a drastic economic impact. And my concern is that at some point we're going to get the green light either prematurely or, appropriately, and we weren't prepared for the surge of patients, and that we won't be prepared for the surge of employees. And when you're not prepared, when you rush, that's when mistakes happen. And you might have 10,000, 50,000 employees, and you want to get 50% of them back to work. That's a huge lift. It's a huge lift if you're prepared, and it's obviously an even bigger lift if you're not prepared. And this is about getting back to work. But the last thing we want is for your 50,000 employees to come back, get sick, and go back out. So we need to avoid that second wave, that third wave, and can't stress enough. Plan, and take advantage of the laws that support a return to work in a public health environment to protect you, your employees, and the public good.
That's really great, both of you. Thank you very much. Andrew, we've had some questions. We can pass your links to the models to all comers on that. There's no problem with that, right?
I posted an URL into the chat that was just then re-forwarded by the administrator for this webinar. So in the chat, there is a tiny URL, and EHE is free to send it out. The mapping tool is a public tool. I think we have the bandwidth to sustain a lot of people using it. But in the in the chat sidebar, I posted what's called a tiny URL, and send it out, David.
All right, so in conclusion, thank everybody. It's been a really informative session. Most of you probably have heard that today we at EHE Health, we did launch our new Safe at Work management system for all of our clients and others who are interested, and strategic partners. We're big believers in public health. We also believe that getting the country back to work again is going to benefit all of us. And any way that we at EHE Health can help, we're here for you. You can contact me directly, or anybody or anyone on our team with whom you work directly. So I want to thank Andrew and Delphine. We really appreciate it, and all the support staff who helped put together this webinar, and look for an invite for another follow-up for part 2 of this series in about 2 weeks. Thank you all.
Thank you all.
Thank you.